Good afternoon, everyone. My name is Dr. Mariam Doreen Joseph, and I'm a geriatrician and consultant physician. Today, I'll be with my colleague, Dr. Nasreen, the obstetrician and gynecologist from Southwestern area. We will be the master of ceremonies for today. I'm very delighted to be here today for the launching of the first Assyrian Medical Association, which you will hear about it more later from my colleagues. I would like to begin by acknowledging the traditional owners of the land where we are meeting today. I pay my respects to their elders, past and present. On behalf of the organizing committee, I would like to welcome you all to this event. I will ask my colleague, Dr. Nasreen, to welcome certain organizations and committees and individuals.
Thank you very much. Good evening, everyone. I hope that you have a good time. I would like first to really acknowledge, all our guests. In particular, I acknowledge Mr. Daly, the Deputy and Mayor of Fairfield and Fidel member, Fawa, and Mr. Guy Zangari, the State Member of Parliament for Fairfield, and also the Fairfield Councillor, Mrs. Carmen Lazar. Thank you for attending this event and sharing these few hours with us. Of course, I would like in particular to acknowledge the sponsor, as without them, this event will be, difficult to organize. My big thanks go to first sponsor, Lavati Pathology, and second is West Side Medical Imaging. I also like to thank Fairfield Forum Pharmacy. I would like also to thank Novadex, and I would like to thank High Performance Health. Thank you very much, sponsor. I would like also to acknowledge and extend my thanks to the other representative group. I would like to start with the church representative from Assyrian Church of the East, Ancient Church of the East, Syriac Catholic Church. Thank you for attending. With no particular order, I would like to acknowledge all other associations with joining us tonight. I will start with the Assyrian Association, Assyrian National Council of Australia, Assyrian National Federation, Assyrian Sport and Culture Club, Chaldean League, Tuluskuf Association, and Coalition of Assyrian Party in Australia, CAPA, Assyrian General Conference, Iraqi Australian University graduate, and Australian Iraqi Medical Association, Assyrian Aid Society, Assyrian Khabur Association, and Mandayan Organization, Chairman of Australian Assyrian Art and Literature Foundation, Director and Councillor of 3ZZZ Ethnic Broadcasting Association from Victoria, Assyrian Culture and Social Youth Association, Status, Committee for Defending Religious and Ethnic Group in Iraq, Mesopotamian Cultural Association, and Assyrian Culture Association, and also the Iraqi Health Professional Association, the Iraqi Australian Christian Association, Assyrian Democratic Party, Assyrian Democratic Association, Bet Nahrim Party, and all the members from Sydney Southwest Area Local Health District Service Multicultural Committee. Thank you very much. Without you, we couldn't proceed with this event. Greatly appreciated. Enjoy your evening.
Thank you. What a challenging few years we had to endure during the pandemic and especially the lockdowns. No doubt, almost every individual have contributed greatly during these periods, but more the frontline workers who endured a great deal of pressure and demands to protect themselves and others. Frontline workers have been experiencing high work volume, personal risk, and societal pressure to meet extraordinary demands for health care. We would like to pay our respect and gratitude for the outstanding job they all did and are doing. I would like to mention few housekeeping notes before we get started. Firstly, can you please put your phones on silent? Secondly, I would like just to probably point out the fire exit. It's that way at the entry of the room. Restrooms are just outside the entrance of the hall. To find any staff to assist you, look for the staff with who have ID badges, or just approach me and I won't charge you for it. There are membership forms on the registration desk. Anyone who would like, any doctors who would like to join us, please get a copy of the membership form. If you don't know what are the constitution and how you can join, you can ask, don't ask me, but ask the secretary of the association, Dr. Daniel Sada. We're just going to get him to do more work today. Also, I have left some blank papers on the tables, and what we really like is for you all to register again by putting your name and by putting your email address. As long as the email address is valid, it's recent, and you know the password. Otherwise, we can't reach you. We have some of the information of some of the members attending today. We don't have everyone. You don't have to provide your phone numbers, but please your name and emails. That will be enough for us. So there are blank papers on your tables and some pens. Please fill it, and later I will get some of the volunteers to come and pick it up so we can put it in our data system so we can use it in the future. Today's program will be 3 segments. The first one will be speeches. We can't get away without speeches. And the second segment will be lunch and also getting to know and introduce each other and socialize. And the third segment will be mainly for doctors. We will have a presentation and also we will have some questions and answers, but we will get our sponsors to talk about their products. I would like to thank a lot of people who made this day possible. First thing, thank you for attending our function today. We truly appreciate it because I know not everyone will be very excited to be here on Sunday, but we will compensate it for you. On your way out, you will get 2 tickets, flight tickets to Bali with $5,000 cash in. Yes. And yeah, not everyone believe me and excited because I'm not Oprah Winfrey. Maybe one day. Look, I like to thank the committee members who really have done outstanding job, and a lot of them behind the scenes. Thanks to the Assyrian Cultural Club for hosting our event. I would like to thank a lot of people, but we don't have time to go through each one. But committee members, the guys who created nice logos, and also the science and the video personnel, IT, and basically every person who's been here. We appreciate your support and coming today and joining with us this historical day. I will now pass the microphone to younger generation because we are getting older. We're getting tired by just speaking for 15 minutes. So we will call some of the medical students who introduce our speakers for today and also to give us some break. So I would like to call Marianne Alkas to come and introduce herself and also introduce the speakers. Thank you very much.
Thank you for that warm welcome, and thank you everyone for joining us today. As Dr. Joseph mentioned, my name is Marianne, and I'm one of the 6-year medical students studying at UNSW at the moment. And I'd now like to call upon firstly Mr. Guy Zingari, who's the State Member of Parliament for Fairfield, just to come up and make an address.
Thank you very much, Marianne. Distinguished guests, ladies and gentlemen, before I say a few words, I would like to acknowledge traditional owners of the land and pay my respects to past, present and emerging elders. Can I also acknowledge the presence of the esteemed guests who are here, to the Federal Member for Fowler, Dai Lee, also Deputy Mayor and Councillor, also to Councillor Carmen Lazar, who is here as well, to Reverend Fathers, and may I also say to every representative from all the associations within the community here. It is wonderful to see you all, so many friends working very, very hard. But particularly today, we are here to launch, of course, the AAMA, the Assyrian Australian Medical Association. And this is the right time to do it, I would say, because we have come out of a pandemic. And just speaking to David before about what COVID has meant for everybody. It has meant, yes, people have been sick. Yes, people have been suffering from long COVID, but also that people are struggling with other illnesses. And this is the right time for an association like this to actually start. And I'd like to thank Dr. Daniel Sada, Dr. Nessuine, and also to Dr. Miriam Joseph for their hard work and the committee members in getting this up and running. Now, as I speak to you today, I must say I was very, very impressed and humbled and honoured to be introduced by somebody who I've known for a very, very long time. Now, I don't mean to embarrass her, but to my immediate right is Marianne Cass. Now, I've known Marianne for many, many, many years because she is still my daughter Talia's best friend. So as someone who has seen Marianne grow up, and to see that Marianne is now the younger face, the emerging face of many, many within our community in the medical field, fills me with great pride. And I can say it fills me like a fatherly pride to be introduced by Marianne. Marianne, we're very, very proud of you, and I know your mum and dad are, but so is everyone here. So if this association can in future inspire the young minds in our community to take up something in the a profession within the medical faculty, that is really good for us. It's good for the community, it's good for the mums and dads, but more importantly, as an Australian community, it's even better. Because now more than ever, we need to get health practices out there. We need to get people talking about what it's like to live in a post-COVID world, because the world has certainly changed. I'm going to leave it there, other than to say congratulations and best wishes, and back to you, Marianne. Thank you.
Thank you, Mr. Zingari, for that great address, and thank you also for your heartwarming words. That was really kind. I'd now like to call up Mrs. Dai Lee, the Federal Member for Fowler, to give her address.
Shlama Lokhan. Good afternoon. Thank you to my dear friend, Councillor Carmen Lazar, who just gave me a quick lesson in Assyrian then. But before I begin, I would like to acknowledge the traditional owners of the land upon which we gather this afternoon, the elders both past and present. And I thank you, Dr. Miriam Joseph, Dr. Daniel Sada, Dr. Nasrin Shammers, for welcoming me so warmly. I also like to acknowledge, of course, my councillor colleague, Carmen Lazar, a state member for Fairfield, Guy Zangari. Many friends in this room, many friends, including my dear friends over there, Emil Joseph and Emmanuel Sada. There are quite a few, as well as distinguished guests and reverend fathers. I know that the Mayor was also invited to attend, but he sends his sincere apologies because he's with his family today. I think it's such a great thing to have a medical association being formed, such as the Assyrian Australian Medical Association, bringing together diverse thinking, diverse perspectives from within a community to work together for the benefit of the community. And I think an association like this, of course, would have the community's interests at heart more than anything else, and in particular, the community's health interest at heart. I know that, you talk about this organisation, acting, being the body to deliver messages to the public in its own languages when it comes to public health. And I know, I'm also aware that you also will be, obviously, it's a new organisation, you'll be looking for funding in order to grow this organisation. An association like this, at this point in time, is very, very important for our community, which is one of the most culturally diverse communities in the whole country, actually. Fowler is the second most diverse, if not, I always say, I claim it as the most diverse electorate in the whole of Australia. So we have special needs out here. And as many of you know, we've had many settlements of refugees in the last few years, and they have special needs from health, from mental health, from settlement issues. And I think in particular for the Assyrian community, you've got the skills in that community to help and enable those individuals to integrate successfully and with good health into our community. So as, obviously as a newly elected member of Fowler, I will be here, my door will be open to assist the community in order for you to get the necessary resources that you need to grow and thrive as a successful community. I've been the last few weeks, obviously, trying to set up my office. I have taken over the office of Chris Hayes. So those of you who have visited Chris Hayes' office know that's in Cabramatta. It's not very accessible, unfortunately. That's what I've inherited. I will try to make it accessible as possible for everybody in the community to come and see me on any issues. So I just want to congratulate the leaders in this community, obviously to you, Dr. Miriam, and the committee, who have decided to create this kind of network in order to represent your community, in order to collaborate, in order to be the voice of the Assyrian Australian community, obviously to the wider public and to the wider Australian systems and institutions. As many of us know, those institutions are still predominantly very much Anglo-centric, Anglo-Saxon and Anglo-centric focus. So any advice you have to those institutions, I have no doubt they will be welcoming. Once again, for congratulations to all of those who have come up and formed this organisation, and know that I'm here. Please do reach out, and I look forward to be able to work with you and walk with you as we travel and build our community up. Thank you. Basim, hang on. Basim Barama. Thank you.
Thank you, Mrs. Lee, for that lovely address and the lovely use of Arabic as well, and for all your efforts to continue supporting the community. I'd now like to call upon Fairfield Councillor Mrs. Carmen Lazar to please make her address.
Thank you very much. I too would like to acknowledge the traditional owners of this land that we are meeting today and pay our respect for past and present. Doctors, distinguished guests, religious leaders, good evening. I am privileged to be standing here today before you at the launch of the Assyrian Australian Medical Association. Our community endeavours for all your amazing doctors who had helped so many, especially during the COVID, when I needed assistance to help our community. I remember when I contacted Dr. Miriam Joseph one early morning asking if she could help, and without any hesitation, she invited all the Assyrian Chaldean doctors to assist. Our community and I have witnessed the high quality and the sophisticated seminars, Zoom meetings, lectures, video clips, and radio talks that were delivered to various communities in 3 languages, in New South Wales as well as Melbourne and international at large. Our doctors kept up to date on a daily basis with the most advanced research and studies locally and internationally. Those talks and the collaborative efforts of doctors, community, and religious leaders were the most imperative factor that raised the public health awareness about COVID, tackled the misinformation, and raised the vaccination rate from 10% to 90%. During those days, we considered ourselves true soldiers who have the responsibility to protect our people and country. I would contact Dr. Joseph at very early or late hours of the 7 days a week. There was no one that day we did not speak, to plan the next step. Being busy with her hospital work, and especially during COVID, running her private clinic and visiting nursing homes. In addition, having a family to look after, she never hesitated to offer help and support to all whenever she was asked to do so. Her Facebook page was updated on a daily basis to give updates and spread essential information to the public in 3 languages. She remained strong and positive and ensured to radiate positivity through her public social media posts for the community to inspire. She did inspire so many through those difficult times. The engagement of our doctors with our community, communicating in own language, was the drive behind the success in surviving the pandemic. Thereafter, establishing such association was very essential, and it would definitely be a bigger drive to tackle various diseases and health problems to raise public health awareness and promote physical and mental well-being in our local areas and other states. The association also pledges to help younger population in guiding them to career choices and future employment. It definitely teaches all younger health professionals to lead by example and give back to the community. We pledge to support and help such great projects. Congratulations on forming this fantastic initiative, and I wish you all the very best. Thank you very much.
Thank you, Mrs. Lazar, for that address. We're now going to move on and hear from some of our association's board members. And starting off, we've got Dr. Albert Yusuf, the Honorary President of the Association, who's going to give his opening speech.
Thank you, Marianne. Delegates, colleagues, ladies and gentlemen, it's a great honor standing here today and launching our Assyrian Australian Medical Association. It is a dream come true for many other doctors, including myself. We thought about this in early 90s. It was Dr. Mariam, myself, and a couple of other doctors that we tried to establish an association like this. We couldn't manage at the time, but hopefully this one will be the start and we go ahead with that. Our association includes a wide range of medical doctors, including GPs, specialists, medical students, and retirees. Our doctors serve various states in Australia, more so locally in the southwest Sydney area, and particularly Fairfield, Liverpool, Campbelltown, Bankstown areas. Most of our doctors are refugees or immigrants who started their life in Australia from scratch. Each one of us has a story to tell. As refugees, we doctors had to heal ourselves first. work hard to get our recognition from Australian Medical Council. We worked hard on that, and then we had to work on our communities, which themselves had a lot of hardship. We are proud to say that most of us speak at least 3 languages. And this has helped tremendously in raising the awareness in our communities, our population in Australia, being Assyrian, Chaldean, Syriac, or Arabic-speaking communities. Many of the members have served the local communities from early on in early 90s actually. If you search the web, you can see a lot of doctors that we worked individually to educate our communities. If you search for Dr. Mariam Joseph, Dr. Albert Yusuf, Dr. Daniel Sada, you can find a lot of locations in the web that actually there are our names and our education material there. We actually helped and arranged some seminars, medical conferences, radio talks, and writing in multiple magazines and even in TV shows, Assyrian TV ones. For years, we have guided many doctors finding their path to employment and education. Today, we want to put all these great efforts under one association name, Assyrian Australian Medical Association. We thank the public, the community leaders, and religious leaders for showing great support for us and working hand in hand with us. We pledge today to continue to serve our communities and to serve our new country, Australia. We'll be very proud to serve as much as we can. We are saying thank you for Australia and for the governments of Australia that helped us with this. Thank you very much. Thank you.
Thank you, Dr. Albert, for that address, and I'm sure everyone can agree that it's really lovely that a vision that you had in the 90s has finally come to fruition, and we hope that the association is everything that you had sort of dreamt of from there. We just wanted to make a special note that we've got an Assyrian calligraphy artist with us here today, so if anyone wishes to have their name written, you can see him at the back. I'd now like to call upon Dr. Toma Michael, who's the Vice President of the Association, to give his address.
Good evening, delegate, church and community leaders, ladies and gentlemen. As a Vice President of the Association and the head of Victoria Division, it is an honor standing here and taking part in the establishment of the first Assyrian Medical Association. I welcome you, all of you. Thank you for attending and making this to happen. During the COVID-19 pandemic and the lockdown, the importance of health professional engagement with the public became paramount. The collaboration between the health professional, church, community leaders was one of the main steps that led to the positive engagement of our community in following the public health orders. The link and the collaboration between Victorian and New South Wales health professionals received as a good gesture by the public and raised the awareness of the confidence in health professionals and their advices. Using clear and simple mother language explaining health matters received very well by the public. Our doctors raised the awareness and worked 7 days a week, hardly during pandemic to help the community understand the scope of the pandemic. We will continue to raise the awareness and work with the health expert to service the community the best we can. There will be also emphasis on promoting guidance to the students and employment opportunities to younger generation and promote volunteering in various health areas. Thank you all for sharing with us this special day, and we hope we all work on the betterment of our health system at large. Remembering that COVID pandemic is not over yet, and we all keep, as a medical association, the hard work and support all the way. I especially want to thank the member of the board who supported to this opportunity to happen. I'm here today, and I especially thank all of them for their support and serving the community. My all dear colleagues, Doctor, thank you all of you. And special thanks to Dr. Mariam Sarkis. Sorry, because I shared with her a lot of education. I myself from Melbourne and her from Sydney, we have a lot of interview together. Thank you, Mariam, for making this to happen to me. Thank you very much, and thank you all of you.
Just wanted to welcome Termida Payam Jazia, who just joined us. Thank you very much. And Yasmin, thank you very much. I'll pass it to Anne. Thank you.
Thank you, Doctor. Hi, everybody. My name is Anne Lazari. I'm a third-year medical student at AUM. I'm going to do a quick introduction to Dr. Arsalan Hermes, who's going to come up really quickly. really quickly. And going to basically talk about the aims and goals of the association. Thanks.
Thank you for your kind attendance here today. We're greatly honored by your presence. And you've made our day by coming here, so thanks again. COVID did a lot of bad things to us, but let's get at least a few things good out of it. A few months ago, probably now a year, we got together to talk to the community that was in big and genuine and deep need for people from its own to basically talk to them about COVID, about the vaccines, and other health concerns they've had. This was easily justified by research that came out a few months ago that showed in Australia the death rate from COVID was 10 times higher in people born in the Middle East and North Africa compared to the rest of the nation. If that did not justify what we're here for today, then nothing should, and nothing would. The Assyrian Australian Medical Association is a non-profit professional organization that gathers all the doctors and medical students from around the country to help them through their journey in the medical system, improve and promote health awareness, education for themselves as well as the community, look after their well-being, and get that community in here in this part of the world a fair go at having some easier access to information in their own language from people that they probably identify more with. We are striving as well to liaise and cooperate with the authorities to the best interest of everyone. But in particular for this community that was, as Councillor Carmen said, quite plagued here with misinformation to the level that the take-up for as simple as the COVID vaccine was 10% in the early stages. So the need is definitely there, the work is big, and we need everybody on board. The other reason for this organization was to improve networking. I got the pleasure of meeting and the honor of meeting many other colleagues that I was not aware of that worked hard and wide for many years, some of them for decades around the country. That networking has proved vital as well in reaching out, as well as improving ourselves from the medical point of view, as well as the social and various aspects. We hope for this association to grow bigger and be another example for other professionals from non-medical backgrounds in this community, the Assyrian, the Chaldean, as well as the Syria community, in addition to all the other brother and sister communities around the country, to find this example of cooperation beyond any previous kind of cultural divisions, any language barriers or so on, to find that soul of bringing everybody together for the benefit and the best interest of our communities here in Australia. And thank you very much.
Okay, thank you so much, Dr. Arsalan. Okay, now it's time to Netflix and chill. We're going to call on Dr. Daniel Sada, who's going to do a short presentation. So just, there's a screen on that side and a screen on that side, and the presentation is going to be on medicine in ancient Mesopotamia. So enjoy.
Respected religious and community leaders, honorable members of parliaments and politicians, members of the community, my fellow colleagues, good day and welcome all. I'm Dr. Daniel Sada, a family physician and the secretary of the Assyrian Australian Medical Association. It's humbling for me to be talking to such a great audience, and I'm truly honored. I acknowledge and respect you all. I also acknowledge this great country and its traditional custodians. My presentation about medicine in ancient times is not to indulge and preoccupy ourselves in the past, or to shine light and glorify one group or another, but rather to have an insight about the advanced knowledge of our ancestors in ancient Mesopotamia, a place which was primarily centered in what's known today as Iraq. This is also to acknowledge and pay respect to the First Nation people and direct descendants and traditional and rightful custodians of our homeland and rich heritage, and those are the members of our community. Just like we always do in acknowledging the First Nation people of this great land on which we are gathered today. It's purely paying respect to a much-deserved people. This is the statue of a great Greek physician called Hippocrates, and in our medical community is regarded as the father of medicine. And we recite an oath named in his honor, which governs the ethic of our practice as doctors. He lived around 400 BC, and even though neither the oath itself nor other treatises or medical texts attributed to him were written by himself, we accept this reality and respect it. Reality and fact, though, can be completely two different things. The earliest discovered medical records were composed in Sumer, southern-day Iraq, in the second half of the 3rd millennium BC, written in Sumerian language in cuneiform texts. These records contain therapeutic procedures in connection with eye diseases. From Babylonia, we have Akkadian texts from the first half of the 2nd millennium BC, describing diseases, procedures, and healing drugs made from plants. During the first half of the 1st millennium BC, when the Neo-Assyrian Empire was at its peak, we find large number of written resources and scientific texts, which even names the scholar, Ishagil Kin Apli, who was responsible for the editorial work which led to the serialization of these texts in the middle of the 11th century BC. This is one of the tablets in the British Museum of what's called Nineveh Medical Encyclopedia, which is a collection of tablets representing a single highly structured compilation of medical knowledge with 12 interconnected treatises. Each treatise centers on the diseases of certain part or system of the body, and each one consists of more than one tablet, which now been called chapter. What's more amazing, they were written and described in systematic and methodical head-to-toe approach, which is a system still in use in our clinical practice. The first 5 chapters devoted to the head diseases in general, followed by 4 chapters for the eyes, 1 for the ears, 6 for the neck, 1 for the nose, 2 for the teeth, 6 for lung and respiratory diseases, 5 for digestive tract, 3 for kidneys, 5 for intestine, and finally 4 chapters for the legs and feet. Such a great work in ancient times, which one can comfortably call scientific and academic, could only be found in a great place which served as a hub of knowledge during those times, and that was Ashurbanipal's library. Found in the archaeological site of Kuyunjuk near city of Mosul in modern-day Iraq, in what was then Nineveh, the capital of Assyria. King Ashurbanipal was fascinated by all kinds of scholarly activities, and by collecting all the knowledge at the time in one place, he not only managed to preserve and protect it, but established a place to study, learn, and research. It was the destination for enlightenment and source of knowledge to everyone. While we respectfully acknowledge the regarded father of medicine for now, work is underway and researchers and scholars are translating and piecing together more of those tablets in the British Museum in a project titled Introducing Assyrian Medicine, Healthcare Fit for a King. And more findings and facts will come to light. Nonetheless, if Hippocrates is the father of medicine, it's very clear who father of all knowledge is, and deservedly and respectfully so. My final words go to our future generation, to our youth in general, and medical students in particular. This is your heritage more than anyone else. Embrace it, claim it, and respect it. It can empower you, galvanize you, and motivate you more than anything else. It's the best drive one can ever dream to have in order to excel and innovate for a better future, for yourselves and for humanity at large, and in you we trust. Thank you.
Thank you so much for that presentation. That was awesome. Okay, I'm going to now call or introduce the Central Board of Directors for the association. So I'm going to call you out, and then if you could please make your way somewhere here to take the official photo, the first official photo for the committee. So I'll start with Dr. Albert Yosef, who is the acting president. Dr. Fidel Metzi, who is the president. I think I'll just call everybody and then you guys can clap at the end because there's like 12 people. So Dr. Toma Mikhail, who's the vice president and head of the Victorian branch. So Dr. Mariam Joseph, who is the head of Media and Communication Committee. Dr. Milad Yohanna, who's the treasurer, but he's unwell today, so he's not with us. Is that correct?
He's unfortunately covered.
Yeah. Dr. Daniel Sada, who's the secretary. Dr. Ben Toma, who is responsible for grants and sponsorship committee. Dr. Arsalan Hermes, who is the chair of Education Committee. Dr. Nasreen Shamas, who is the co-chair of Education Committee. Dr. Milad Shlemun, who is in the IT department, and he's also part of the Members Wellbeing Committee. And Dr. Sarmad Behnam, who is part of the Doctors and Charity Committee, and Miss Marianne Cass, who is the Undergraduates and Medical Student Committee. So thanks, guys, and yeah, take a photo. Okay, and now it's, I think this is everybody's favorite time. I got told before that I wasn't making eye contact, so I'm making eye contact with everybody. Anywho, so lunch is now ready, so it's an open buffet and it's on that side, so please help yourself and enjoy the rest of your time. I think it's 1 hour free time with lunch, and then we'll commence with the last segment.
Just wanted to point out about the last segment. That's more scientific segment. So the doctors are welcome to stay. The public, we would love to have you, but I think you will be very bored with the medical talks. So enjoy the lunch and please touch base with each other. And again, thank you very much. It was lovely having you with us today. Thank you.
Hi everyone, so we'd now like to call upon some of our sponsors who've attended the event, starting with Lavity Pathology. They'd like to come up? Yeah, great.
Thank you. I would like to thank the Assyrian Australian Medical Association for giving us the privilege of supporting and sponsoring this function. As you probably know, Lavity Pathology is one of the largest pathology providers in New South Wales. We fall under the umbrella of Helios Pathology. We have Dorevich Pathology in Victoria, Queensland Medical Labs in Queensland, Western Diagnostic in West Australia, and Abbott's Pathology in South Australia. We have been one of the first forerunners for testing COVID when the pandemic hit this country and the world. And we were the first to introduce the 24 hours COVID testing in Fairfield. We pride ourselves as still doing bulk billing for most of the patients that are being referred to us. We have around 700 collection rooms around the state, and almost half of them are in Sydney Metropolitan. We have recently also introduced the e-referral system, whereby during doing a telehealth consult, you can send a pathology request to your patients by a text message. This facility is only available for best practice as your practice management system, but Medical Director is working on their version, which will hopefully be available very soon. If you like any more information, you can find it on our website, lavity.com.au, or you can give me a call or any of our colleagues, and we'll be more than happy to help you with that. Thank you all again for having us, and thank you very much, Dr. Tuma, Ben, and Dr. Mariam, Dr. Daniel, and we'd like to see you again next year, maybe. Thank you.
Thank you very much for that, and a huge thank you to Lavity Pathology, who has been a major sponsor for this event. And without your generous contribution, we, wouldn't have been able to put this all together like we have. Next, I'd like to call upon Westside Medical Imaging. Okay, yep, he's coming.
Hello, everyone. My name is Tomo Nishiguchi. I'm director and radiologist in Western Medical Imaging. First off, thank you very much for inviting us to this, nicely organized ceremony in the Assyrian community, and I really appreciate that for Dr. Sada. So we are newly open radiology practice in between Smithfield and Weatherly Park in Market Town next to Bolrama. So we just opened in March this year, and we are providing basic bulk billing services, including X-ray, ultrasound, CT, and in addition to them, we will be launching 3D mammogram this August and start MRI services next year. And we do all kind of injections, procedures, and we accept all referrals. As Dr. Albert Yusuf commented on, many people in the Syrian medical, in the medical industry in Australia, immigrants, and they spend lots of time to go through the exams and qualifications. I'm originally from Japan, and I'm also one of these people to spend lots of time to go through the accreditation. So I know how hard it would be for all doctors, all hardworking doctors. So we have quite numbers of multilingual staff, including 2 Arabic-speaking sonographers and receptionists. So if you have any questions or any patients, we are more than welcome. Anyone, even if they don't speak English, we can assist them, all the time. So lastly, I will announce this opportunity to local people, local doctors, and all people joining this function here. This is not a referral basis. We are keen to provide best quality, speedy services to the community people. So hopefully from August or September, we will start our so-called West Side MSK meeting. This is a free event. So if anyone, like physiotherapists, specialists, GP, nurses, or technical people who are interested in MSK, imaging, MSK, learning, please join us. We will invite specialists from the hospital and other people who are specialized in MSK imaging and MSK procedures. So hopefully I will announce this event through Dr. Sada or through AAMA portal. Thank you very much again for inviting us.
Thank you so much, Dr. Tom. The next sponsor that we're going to call is from the Fairfield Forum Pharmacy, Mr. Rommel, if you'd like to make your way up.
Thank you, and thank you for Assyrian Medical Association for inviting us here. To be honest, I'm very proud and happy that this finally has happened. It was something we were looking forward to, and like Dr. Albert said, it's long in the making, and I'm really proud and happy to be part of it, even as a sponsorship. To introduce myself, Mohammed Yusuf. I own Fairfield Forum Pharmacy for the past 11 years now. I recently opened Greenway Medical Hub in Weatherly Park, and recently my partner here, Giuliano, we opened another clinic, Medifarm Group in Preston, which Giuliano will talk about that one. Our services, basically what I'm trying to do is to incorporate as much service as I can as a hub, and that includes the pharmacy offering discount, offering NDI services, sleep apnea services as well, which is basically testing, hiring, and sales as well. What else we offer?
So we pretty much offer, as Rommel said, we're just trying to aim at making our businesses to be our one health destination. which our services do provide general practitioners, dentists, pathology, physio, podiatrists, psychology. And our pharmacy, each medical hub includes pharmacies as well. Our pharmacies beat every competitor's price, and if you ever find a product that's cheaper elsewhere, we can just always price match to the price that's the cheapest. Our pharmacies also sell mobility care, which Romel is the big supplier that supplies all the mobility care, and that includes wheelchairs, walkers, scooters, and electronic services as well. Pretty much what we're trying to do, as Romel said, we're trying to make it a One Health destination. In Preston, we have a radiology opening next door, possibly in the next 6 months, and that pretty much just makes it fall within the One Health destination again.
That's pretty much it. That's all our services. Like I said, we try to make as much convenience for our patient to provide all-in-one house service. Thank you.
Thank you.
Okay, thank you so much, guys. The next sponsor that we're going to call is Ms. Sue Carroll from Novardisk. If you'd like to make your way up.
Good evening, everyone. My name is Colin from Novo Nordisk. And firstly, I would like to thank the Australian Medical Association for the opportunity to be here. I look after Saxenda, the only GLP-1 indicated for weight loss. And as you all know, obesity is on the rise, with 2 out of 3 Australian adults are either overweight or obese. And obesity is the second highest risk factor for COVID death, so it's quite relevant. So if you want more information, resources or samples, come and see me, I'm over there. All right, thank you.
Okay, thank you so much. So this is going to be the last sponsor. And it's going to be from High Performance Health, Mr. Emil Joseph, if you'd like to come up. Thank you.
Good afternoon, everyone. My name is Emil Joseph. Just thought I'd say congratulations on launching this collaboration of all the medical professionals, the Assyrian ones. It's been a long time coming, but it's very good to see that our community is working together and supporting each other. So I really look forward to working with you guys. Secondly, thank you for surprising me with the public speech. It always makes me nervous. But yeah, I'm from High Performance Health, so we're a allied health clinic in Wetherill Park. I've been working in the industry for about 10 years as an exercise physiologist. At the moment, we have multiple health services. So we've got exercise physiologists, physiotherapists, we work with podiatrists, we've got a psychologist, occupational therapist with 25 years of experience. So we're quite experienced. We all speak either Assyrian or Arabic. And we've also got a women's health physiotherapist for Dr. Nisreen, where are you? Your clients. But yeah, just really looking forward to working with our local community. We're doing a lot more of disability work as well. So I know some of the GPs get a bit nervous with the access forms that the patients decide to give them. So if you ever need help with that, we're happy to help you as well. Yeah, thank you for having us, and we look forward to seeing you hopefully every year. Thank you.
Okay, thank you so much. So now we're moving on to the second to last segment, which is going to be a presentation or a lecture that will be given by Dr. Fidel Meti, and it will be on lung cancer. Is that correct?
Hi everyone, my name is Fidel, one of the respiratory and sleep disorder physician. I am a part-time staff specialist at Campbelltown Camden Hospital and St. George Hospital, and I'm VMO at Bankstown Hospital. I've got my practice in Fairfield and Gregory Hills. So thanks everyone for the invitation, and thanks for the nice time we had. I'm gonna straight away go to the presentation for the time sake. So I thought we should talk about lung cancer because of the increasing prevalence of the lung cancer in the society, especially in the southwest Sydney, and that's in concordance with the increased incidence of smoking uptake. As you all aware, lung cancer is the leading cause of death in both men and women worldwide, and the lung cancer can be divided into two categories. We have non-small cell lung cancer, which is the most common one, accounting for 85% of the presentations at the time of the diagnosis, compared to 15% of the time as small cell lung cancer, which is more aggressive forms of lung cancer. So most of the patients with lung cancer presented for diagnostic evaluation because of symptoms suspicious for lung cancer or incidental finding of chest imaging. And I guess part of my presentation today is to increase the awareness of lung cancer when we seek attention and when we should think about the diagnosis. This is a diagram of the types of lung cancer. As you can see, by far, large cell lung cancer is the most common type, histopathological types of lung cancer, followed by adenocarcinoma, and then we have squamous cell carcinoma, and then we have small cell cancer as a small entity. This is the incidence of lung cancer from 1982 to 2017 by sex. As you can see here, there is an increase in the incidence of lung cancer in the female compared to a decline in the incidence of lung cancer in male. And that's probably because of the new mutation, which we're talking about EGFR mutation, which it's more prevalent in female who have a history of light smoking exposure or never smoked in the past. So there is increase in the incidence of lung cancer in female compared to the male. So in the initial evaluation for lung cancer, it's important to establish the clinical extent and the staging of the disease because that affects the type of treatment, modality of treatment, as well as the prognosis. It's also, when we do initial evaluation, we optimally target the size and modality of the first tissue biopsy, by which we can obtain specific histopathological analysis and look for molecular markers, which is something happened over the last 2 decades in the management of lung cancer. It's important to take in consideration about the comorbidities and secondary complications and paraneoplastic syndrome that influence the treatment options and the outcomes. By the end of the day, patient values and preference would be an important factor to keep in mind that influence diagnostic and therapeutic choice. Now, there has been an increased awareness of the time where there is an increased suspicion for lung cancer. Most of the time we see incidental finding, which is the most common thing we actually see these days. Patient gets imaging or a modality of investigation for something else. They found a tumor in the lung. And that's probably because, as you're aware, the lung tissue is very collapsible, and you have to have a big burden of the disease before you present with symptoms. On the other spectrum, you can have symptoms of lung cancer, which includes coughing, and any chronic cough more than 3 months should increase the suspicion of possibility of lung cancer, which is present in 50 to 75% of the time. Hemoptysis is really a red flag symptoms of lung cancer, and it's present in up to 50% of the time. Dyspnea and chest pain are other symptoms. Now, if you look at the histopathological types of lung cancer, they can present in kind of different clinical picture. Features that suggest small cell lung cancer is basically progressive symptoms and the presence of paraneoplastic syndrome. They usually present as a bulky mass in the mediastinum with invasion to the underlying structures. In contrast to the non-small cell lung cancer, where they basically present us with the above findings. One of the other important clinical manifestations of lung cancer is Pancoast syndrome, where there's apical tumor presents with Horner syndromes, as you're all aware of it. And then you can have hypercalcemia as a paraneoplastic syndrome due to the excessive secretion of PTH. Now, radiology, lung cancer can present in different ways. The most commonly seen is the solitary pulmonary nodules, including large lesions, irregular or spiculated borders. It seems like the upper lobes leads to be more commonly involved with lung cancer than the other lobes. You can present as a cavity as well, and it can present as a subsolid mass where there is a solid component surrounded by ground glass changes. The findings of multiple nodules in the patients with known or suspected extrathoracic malignancy highly suggestive of pulmonary metastases. Lung cancer can present with mediastinal hilar lymphadenopathy. It can present with malignant pleural effusion. So there's different spectrum of radiological presentation for lung cancer. This is a patient of mine who was referred to one of the local GPs in Fairfield who basically has a history of TB and was presented with increasing shortness of breath. And as a modality of screening for lung cancer, I found left upper lobe spiculated mass, which was biopsy and turned up to be adenocarcinoma. The patient was asymptomatic apart from symptoms of chronic obstructive airway disease on the lung function testing. You can present as ground glass changes. We see that very commonly in lipidic adenocarcinoma, slowly growing, especially in female. This patient biopsy proven lipidic adenocarcinoma required left upper lobectomy. Can present as a big mass, one of the other patients that can invade to the chest wall and to the hilum. This one was turned up to be squamous cell carcinoma. Now, when it comes to the management, I think it's important to assess the patient comorbidities, whether they've got underlying heart disease or what the lung function is doing. They've got other comorbidities, including renal failure. Assess the key ECOG status, which is the functional assessment established by the oncology teams in Europe. Assessment of the respiratory functions. We do complex lung function tests to look at the FEV1 and the diffusion capacity, which are the two important factors in determining the modality of treatment for patients, especially in the early stage, whether they can have lobectomy or resection, or they can have concurrent chemotherapy and stereotactic radiotherapy. Now, staging of the disease is important, and this now is standard of care for management of lung cancer to have everyone having PET scan and endobronchial ultrasound transbronchial biopsy of the mediastinum as a part of the staging. Obtaining tissue, there is modalities to obtain tissue. You can do CT-guided biopsy. If clinically appropriated, you can do bronchoscopy if you have central lesion with endobronchial component. And now, over the last 4 decades, there is what we call endobronchial ultrasound and transbronchial biopsy, EBUS-TBNA, which is really an important standard of care modality of staging of lung cancer. So, after you resect or you treat lung cancer, it's important to have a pathway to monitor for recurrence, because as we know, the lung cancer recurrence rate is high in the first 5 years. Therefore, all the patient needs to be monitored for 5 years for recurrence. This is the ECOG status, which is an important to be taken into consideration for managing patients with lung cancer. So if you have somebody who have early stage lung cancer with ECOG 0, then resection is definitely the modality of choice. In contrast to somebody who has ECOG 3 or 2 and they've got early stage lung cancer, because you don't want to resect lung where there is underlying significant impairment of on the lung function testing. PET scan is now available at Liverpool Hospital, and there are some talk about getting some private PET scan because of the increasing burden at the hospitals to evaluate patients with malignancy. And PET is more accurate in evaluation of the mediastinal lymph nodes when compared to the CT scan because it's FDG uptake. It's determined by having FDG uptake. It determined the lymph nodes were involved. It's a good screening for distant metastases. Keep in mind, PET scan is not good for screening for brain metastases. So if you have somebody who have lung cancer and you want to make sure they don't have brain metastases, they probably should have a CT with IV contrast or MRI of the brain, because the brain tissue normally has a very high FDG uptake. Now, what's the limitation of the PET scan? They can have false positive in other condition, not only malignancy. You can have positive PET scan in infection, sarcoidosis, or inflammation. If the lymph node is less than 10 millimeter, that can potentially be false negative. But when you do EBOS TBNA, you can find micrometastases. So I think it's important to keep in mind PET scan and EBOS TBNA provide the best modality of staging of the mediastinum when it comes to the lung cancer. Now, obtaining tissue biopsy, and as I said, there is way you can obtain tissue biopsy. You can do CT-guided biopsy, you can do bronchoscopy, or you can do EBOS TBNA. Now, before obtaining any tissue biopsy, I think most of the patient, if not majority of them, undergo PET scan to determine which lymph nodes are involved, and it helps to target the area of interest to get the biopsy. The risk of potential biopsy, the risk and potential complication of biopsy might affect the preferred options of investigation. So as we say, CT-guided biopsy, bronchoscopy, EBOS TBNA, you can do pleural aspiration if you suspect patients got malignant effusion. Now, I think a lot of practices do CT-guided biopsy, and this is basically putting a needle to the tumor from outside under CT guidance. I think it's important when it comes to the CT-guided biopsy to determine the site of the tumor and how much of the lungs tissue you're going to traverse, whether there is underlying COPD or emphysema, because one of the risks associated with CT-guided biopsy, and this depends on the one center from another and depends on the radiologist as well, the risk of biopsy is around 25% pneumothorax, 5% of them needs chest tube insertion. So I think the position and the location of the lesion determine whether CT-guided biopsy is safe or not. Then that's the other area we do, which is the bronchoscopy, which is a camera test to the lungs under sedation or under general anesthesia. It's useful for central tumors where you can see them on the CT scan invading to the airways, because through the bronchoscopy you can deliver your instruments to do endobronchial biopsy, brushing, or you do bronchoalveolar lavage. So flexible bronchoscopy is good for central tumors because you can do endobronchial biopsy, but for peripheral lesions or extra lesions that are outside the airways is not a very good modality of investigation. Therefore, EBOS TBNA or endobronchial ultrasound comes as the modality of choice. So conventional bronchoscopy, the use of ultrasound guidance for tissue biopsy enhance the ability of the bronchoscopy to sample lymph nodes and tumor outside the airways, making EBOS the preferred bronchoscopy modality for diagnosis and staging, in contrast to the standard bronchoscopy. And I'll touch base about the EBOS soon. So as we say, the conventional bronchoscopy, just the standard, the flexible bronchoscopy, has a diagnostic accuracy of 65 to 88 in the centrally visualized tumors. However, this diagnostic accuracy declines with the tumor more distally. This is a patient who presented with hemoptysis, and we're looking at the right upper lobe, and there is endobronchial tumor, biopsy proven to be adenocarcinoma. So these types of the tumors, they are best investigated by bronchoscopy, because with the forceps you can obtain a good tissue for histopathological molecular staining. This is EBOS TBNA, and this is a new modality of investigation patients with lung cancer. As you can see, there is a bronchoscopy. At the end, you've got a linear curve ultrasound that actually goes into the airways, and you can see outside the airways you have the lymph nodes, and it's amazing way of looking to the lymph nodes. So there is a balloon you inflate it when you are in the area of target that actually visualize the lymph nodes, and through the bronchoscopy itself you can actually measure the size of the lymph nodes. As you can see here, the ultrasound actually detects the blood vessels in the lymph nodes and determine what is the safest area of biopsying the lymph nodes. Through the working channels, there is a sheet with the needle inside, and that comes out of the other end of the bronchoscopy. And then you, while you're visualizing the lymph nodes, actually you can put the needle in the lymph nodes and take a lot of samples. We target 5 to 10 samples from each lymph nodes. The samples can be sent for histopathological analysis as well as molecular markers. We do these procedures at Bankstown Hospital on Tuesday afternoon, and I do them at St. George Hospital on Thursday morning, and it's actually a modality of choice for staging of the mediastinum, because that's an important when it comes to the staging of the disease, especially for curative intent. These are the lymph nodes in the mediastinum that are accessible by the EBUS TBNA, and there are some lymph nodes where are sitting outside next to the aorta. They are not accessible unless you want to do an arterial blood gas on the way out. Linear EBUS, it's an early study suggested that EBUS TBNA detect malignant lymph nodes up to 90 to 95% with the sensitivity and negative predictive value of 95 to 90% respectively. The major limitation of the EBUS, and again it depends on the operator, a small sample size, therefore you need to do more than one biopsy. It's not available everywhere, so we don't have it in Campbelltown, but we are trying hard to get an EBUS TBNA at Campbelltown. So availability, it varies from one institution to another. Big hospitals usually have the EBUS, and there are some factors that can affect the availability of these instruments. As I said, the EBUS TBNA can access some lymph nodes because of the presence of underlying vital structures. Now we have radial EBUS. The one I talked about it was the linear EBUS. Now we have radial EBUS, which is a good test to look at the peripheral lesions. In the olden days, the peripheral lesions were biopsied by the CT guided, but you know, these patients have significant lung disease with COPD, emphysema. When you put a needle through the lungs, you end up having complication. This can be avoided if you have a radial EBUS bronchoscopy, where you actually can target the lymph nodes via the bronchoscopy, ultra-thin bronchoscopy to the area of interest and get samples. The radial EBUS bronchoscopy has a very positive predictive value of 100% and high sensitivity of 66%, with a negative predictive value of 63 and diagnostic accuracy of 82 when you sampling the peripheral lung lesion. So this is radial EBUS bronchoscopy. So it's again, it's a small camera, goes to the very simple small peripheral nodule, and you can see that on your right, on your top right, how the lesion looks like when you put the ultrasound on. And then once you are here, you can basically put your needle, brush, and forceps to get samples. So this is staging of the lung cancer based on the I'm sure most of you are aware of what's the staging modality of lung cancer at this stage. It's basically TNM. So T is for the tumor size, N for the nodal involvement, and M for metastases. And the higher the TNM staging is, the more likely the patient's got an incurative disease. Prognosis is very bad in lung cancer. That's why early detection and early management is important. And actually, most of the standard of care these days of diagnosis and management of lung cancer is to establish diagnosis in 1 to 2 weeks' time, by the end of this period, the treatment should be delivered. And as you can see, early stage lung cancer had good prognosis because they are curative intent compared to the late stage for the 48 months or 2 years mortality is less than 5%. So staging of lung cancer is important in terms of the prognosis. As we said, the most important prognostic factor in patients with small cell lung cancer is the extent of the disease at presentation. For patients with limited stage disease, median survival range from 15 to 30 months, and the reported 5-year survival is only 10 to 13%. By contrast, for patients with extensive stage disease, the median survival is 8 to 13 months, and the 5-year survival is only 1 to 2%. So it's very poor prognosis. Now, when we do sampling of the lymph node or any lung tissue, cancer tissue, we send for molecular markers. And this is something happened over the last few decades in terms of management of lung cancer. It used to be only a standard chemotherapy with cisplatin and based therapy, but now there is molecular markers where we target the surface of the tumor after you do immunohistochemistry staining, looking for PD-L1 and EGFR. And one of the presence of these molecular markers actually gives you or favors better prognostic outcome. So you can target these molecular markers once you discover them. So just for all the my colleagues, general practitioners, we have what we call Rapid Access Clinic. We call it Rapid Access, but actually the name of the clinic is Rapid Access Lung Cancer Clinic, but we don't advertise it as Rapid Access Lung Cancer because we don't want to frighten the patients. This clinic is present in Campbelltown Hospital, and I do run this clinic on Fridays. We have similar clinic at Liverpool Hospital, and basically this clinic is to keep the GPs aware about early referral of patients with suspected lung cancer, streamline the management and investigation pathway, and we advocate for all the general practitioners to refer the patients with the following criteria: solid lung nodules or mass more than 8 millimeter, semi-solid or ground glass nodules more than 6 millimeter, which has been present for 3 months because could be lipidic adenocarcinoma, lung mass suggestive of malignancy based on the report and the radiology, persistent pleural effusion when some patients have mediastinal or high lymphadenopathy. So one of these criteria, if it's present, we highly recommend a referral to the Rapid Access Clinic. Now, once you, as you're aware, I mean, we're not like gastroenterologists. We do gastroscopy, colonoscopy, screening for GIT cancer. We don't have that luxury. But what happens over the course of years, we only rely on the imaging. And a good respiratory physician knows how to read CT scan. Therefore, we like scans of the lungs. Now, there was multiple papers established in screening of lung cancer, and we're talking about high-risk population, patients with the history of heavy smoking exposure, patients with family history of lung cancer, or patients with the previous history of lung cancer. And this paper was released in a New England Journal of Medicine. A huge number of patients who being randomized to have a low-volume CT scan of the chest and X-ray. And what we found, actually, when the patients, we screened them with annual CT scan, we picked up a lot of lung cancer, and what it translated in terms of the mortality, the lung cancer mortality dropped significantly with the p-value of less than 0.005 in screening group compared to the control group. So Americans do scan patients. I do have actually very low threshold to do CT scan, and so far in my practice over the last 2 years, I picked up 6 lung cancers that have been curatively treated based on the screening with the CT scan. I usually ask the radiologist to do low volume or CT scan just to less radiation to screen for lung cancer. There's some talk about doing bronchoscopy in the next 5 years. Probably, I think there will be some role of bronchoscopy for screening of lung cancer, and it's still in work in progress. So I guess the key message from my presentation today is early detection of lung cancer is crucial. High index of suspicion is required for early diagnosis of lung cancer. There have been a lot of new modalities evolved in the course of the time in terms of diagnosis of lung cancer and staging of lung cancer. Screening in high-risk population has shown improvement in early detection and hence improvement in mortality for patients with suspected lung cancer. I think by the end of the day, I think we all advocate about the importance of smoking cessation, and it has shown that smoking cessation will drop the risk of lung cancer in patients who have been smoking, never get it back to the population who never smoked. And now there are new therapies and new hopes in managing patients with lung cancer with the presence of new molecular markers that can you target. Thank you. Any question? Not for lung cancer. MRI has got no role in the diagnosis and staging of lung cancer. We don't usually do an MRI. CT scan is shown to have very high sensitivity in picking up lung cancer. We do MRI when we think the patient's got an involvement or potential involvement of the brain. So what I'm saying is any tumor of more than 3 centimeters, especially upper lobes involvement, we do MRI of the brain as a staging modality to make sure there is no micrometastasis in the brain, but not for staging of lung cancer. Yes, Ibrahim.
Thank you very much. Fantastic talk. So interested to learn from the teacher, to learn from the students. I'm very happy to learn from you, Fidel.
Thanks, Ibrahim.
And one thing, Fidel, about screening. I don't think so far the screening has been shown to be really effective in lung cancer. One. And second, you are a respiratory physician and you pick up 6 cases of lung cancer. I pick up 5 cases.
I'm sure you do.
Okay,
Yeah.
you remember?
Because they present with the neurological symptoms.
Because what I'm going to tell the general practitioner, paraneoplastic syndrome, there are 90% of them are neurological. They are neurological paraneoplastic syndrome.
Yeah.
That means lots of them are presented to us.
I'm sure they do.
That means this is only 2 endocrine paraneoplastic syndrome you already mentioned, the PTH-related peptide, squamous cell carcinoma, and the IDH syndrome. Except everything else is neurological. They can present it with peripheral neuropathy, they can present it with limbic encephalitis, they can present it with cerebral ataxia, they can present it with even meningoencephalitis. That means neurological patient can present it with this condition. A loss of paraneoplastic syndrome, which a loss of, unfortunately, GP usually they struggle what's going on. And if normal brain CAT scan, this is the biggest problem. If normal brain CAT scan, doesn't mean he doesn't have paraneoplastic syndrome. Even normal MRI scan, you can have normal MRI scan and you still have the paraneoplastic syndrome. Because the paraneoplastic syndrome, you don't need to have metastatic disease. And even it can be occult and you can see the paraneoplastic syndrome 2 years you have to find the cancer. That means just one issue I thought to let you know that neurological manifestation is very common in any type of cancer, and mainly lung cancer and small cell cancer.
Yeah,
Thank
correct.
you.
Yeah, correct.
Thank you very much, Fidel.
Nice.
Can I ask a question as well?
Yeah.
Thank you. So, for emergency physicians and for our GP colleagues here, we often get a CT report that says there's a lung nodule of this size. What size do you want us to call you straight away? What size do you want us to ask you for? So to ask for high resolution chest CT, and is there anything else that we should consider?
So I think it all depends on the clinical context. If somebody's got a low risk for malignancy, and what I mean is somebody who have a history of lifelong non-smoker or no family history of lung cancer, if we find an incidental finding of pulmonary nodule of less than 8 millimeter, you probably not be concerned as in comparison to somebody who has been a smoker, has had a family history of lung cancer. Probably anything more than 8 millimeter, I would be really worried about it. We're talking about solitary pulmonary nodule. If we have multiple pulmonary nodules, I think any nodules of 6 millimeter and above should be assessed by a respiratory physician because this patient usually needs monitoring for 2 years with serial CT scans. Now, what CT scan is good? High resolution CT scan is very good to detect pulmonary nodules. Usually the modality that I use for patients for screening of lung cancer in a good clinical context, I usually send them for low volume, high resolution CT scan of the chest. And it's more than adequate to pick up suspicious pulmonary nodule. I mean, other important things when you look at the CT scan, if the patient's got lymphadenopathy, is important. There are some cases, rare cases, that have been reported. The patients presented with just mediastinal lymphadenopathy as an early manifestation of lung cancer without a pulmonary nodule, which is really interesting because you think the presence of the mediastinal high lymph nodes it's usually a sequelae of presence of intraparenchymal cancer rather than just the solitary lymphadenopathy. But there are some cases. Therefore, we, in a smoker who's got mediastinal or high lymphadenopathy, we actually do recommend them to be referred for an assessment. Yes, Neil.
Okay, just one note. I think like sort of people are not radiologists, they might not realize that having a high resolution chest CT is not something that is a special order. Because all you have to do, if you've got like sort of the thin slices, you just apply a certain algorithm and then you get the high resolution images. And this is like part and parcel in Fairfield where I work. We do the usual and we do the high res in the same sitting, right? Only time, of course, like sort of if you want to like sort of look at something in the lung bases because the patient is lying down and that compresses the lung tissue, so you get them to lie prone yeah. And all like sort of sometimes right lateral and left lateral, they can't lie prone to analyze what's happening in the lung bases. But in general, a normal CT, you get the contrast and you get also the high resolution with it. So that's basically a given. You can ask your department in Campbelltown to just include it, like it's part of, it's just basically 2 more minutes of processing by the radiographer. It's not a big deal, just like sort of, get it done and cooked and you've got everything ready, right? The other thing is like sort of when you mention those people who come with like sort of lung malignancy that only manifests as a pleural effusion, and then you aspirate the effusion and there's nothing there, no cells or whatever. Do you think like sort of it's better to try to get a pleural biopsy rather than, sort of waste time with the, or in the same sitting, like, you take the effusion and take a pleural biopsy as well?
Yeah. So I think, pleural biopsy, you can't do it everywhere. I mean, we used to do them at Westmead. We use Abraham needle closed pleural biopsy. It's not a very good diagnostic test for lung cancer. It's good for TB, as you're probably aware of. But I think if somebody came in with pleural effusion and then you aspirate the fluid and there is no malignant cells and then you have still high index of suspicion, I would recommend having PET scan prior to that. It's probably not going to be funded because of the criteria, but PET scan will help you what part of the pleura you can target by biopsy, because you don't want to put a needle in somebody's pleura and you don't get malignant cells and then you still have to do the procedure. So a lot of time when somebody presents with pleural effusion that's not resolving and we have a high index of suspicion this is malignant, we actually do PET scan. PET scan will show us, unless it's mesothelioma, the PET scan will show us which part of the pleura you will be targeting in biopsy. Still, PET scan would be helpful in determining, which part of the visceral parietal pleura would be you'll be targeting.
But it also probably can be positive with infection, isn't it, as well?
What's that, sorry, Neil?
Can it be also positive with infection?
Correct, yes. So, I mean, it's really hard. So I think you need to take into account the clinical presentation. If somebody's not febrile and don't have any features of infection, they have significant weight loss, they've got effusion that's not going away, and, they are smokers, I think you should think about that. In contrast, somebody's got fever and, has got features of pleural infection, that's a completely different entity.
Do respiratory physicians kind of look at Fleischner Society?
Yes.
So
yes,
you follow that?
Yeah, they are very important guidelines. Yeah. However, I mean, by the end of the day, there are guidelines to help you monitoring patients with lung cancer. Yeah. By the end of the day, you have to use your clinical judgment on what's the interval of monitoring these pulmonary nodules. I tend to do them a bit more regularly for patients who are heavy smoker. And you're probably aware, Neil, there are some features on the pulmonary nodule that increase the suspicion, the speculation, the upper lobes lesions. I usually tend to monitor them a bit more closer than the Fleischner Society guidelines. Yeah. Okay. But they are very useful tools to monitor for pulmonary nodules, definitely.
Okay. Thanks a lot.
No worries, Neil. Thank you. Okay. Thank you.
All right. We will come to conclude our meeting for today. And I would like to also, before I conclude the meeting, to thank our sponsors again, Levity, Westside, Fairfield Forum Pharmacy, Novartis, High Performance Health. Thank you very much. I would like to thank you all for coming today and sharing this special occasion with us. I wish you all the best. We are gonna probably organize some conferences, not in the near future, but at some point, and we would love to have you again. We have a wide variety of expertise, and I'm sure that good sessions will be quite interesting to all. And we would like also to accept any ideas or from younger generation, older generation. We would like to work together to produce better care and also to help out the community in various ways. The reason for this association was, as we said, that during COVID-19, we realized that the community needed us to talk in our own language, in our own way, present various topics, and specifically COVID-19. And we realized that it's not just about COVID-19. We can have a lot of different diseases, and we need to work together. The community were so grateful to all of you doctors who you have done an amazing job. Number one, to see your patients, to give your support during COVID-19. All of you have contributed, and not just doctors, all the health professionals. Everyone has contributed a great deal, and we thank you for that. We realize that the community need us to really talk with them, to be close to them, and to answer their questions. And this is why the idea of planning or organizing or forming this association came from. As we discussed, and we said that we can communicate in various languages, and this is where we can conduct or pass our messages in various ways. You are welcome all to come and share and help us with these things. I'm sure we have great expertise sitting in the background. We want you all to come and help. We are here just opening the pathway to all of you to come and help and contribute, because we all learn from each other. We need to improve the healthcare, the public health awareness, and also the care of patients. At the same time, we need to exchange expertise and information. We all learn from each other. Every day is learning. No one can say, I know everything. So we appreciate all your support during the last couple of years. And today, we're really grateful, and we are very happy to see you all here today, and we wish to see you in the future event. Thank you very much to all.